Yeah. So a very good morning, students. Let me check my audible. A very good morning, students. Let me. Very good morning, students. Yeah. I think I'm audible now. Okay. So, uh, as you know, students in epidemiology, the epidemiological methods, the different types of methods which is used whenever we are doing any study, it becomes of paramount importance. So what we'll be doing today, students, we'll be trying to take this epidemiological methods, how better we understand this, first of all. Good morning, Meena. Good morning, Prachi. How better we understand, and we'll try to understand the concept of different methods, followed by we'll take few questions also. The questions will be just to make us understand that the concept which we have made, is it helping us to solve the questions or not, right? So let's start. And today in the evening also I have a YouTube class. So in the evening you can join on at 8:30 p.m. I'm also taking special classes also. So these are the links. So I'll request you all to join to get maximum benefit of this. Okay, so let's start. As you know, whenever we have to decide or study about epidemiological methods, can we understand in this way, students? Let's try to see this. So this is epidemiology. If I say, can we study epidemiology, study of distribution of disease? I want to study the disease distribution pattern, where the disease is happening, when the disease is happening, who all are affected. So can I say study the distribution of disease with reference to time, place, and person, right? We can study epidemiology with respect to time, place, and person. If you are studying epidemiology with respect to time, place, and person, this is called descriptive epidemiology. You are basically describing the disease, so it becomes descriptive epidemiology. You have described the disease with respect to time, with respect to place, with respect to person. Now, so this is first component. Let's take the second part. If you're studying the etiological risk factor of the disease, you're trying to study the risk factors. So if you want to study the risk factor, you can study that by either moving forward, which is prospective study, or you can move backward, which is retrospective study. So when you are trying to analyze or trying to understand or try to study the risk factor either going forward or either going backward, so can we say this as an analytical epidemiology, right? Now, see, two things we have studied: distribution pattern, and second is risk factor. You're trying to understand the risk factor of the disease. Once you know the distribution pattern, once you know the risk factors, what will you do? You will try to give recommendations for prevention and control, because you want to prevent and you want to control the disease. For that, what you do epidemiological investigation. So this part, can we say that it is an applied epidemiology? So whatever knowledge you have gained from descriptive and analytical epidemiology, you will try to formulate prevention and control by doing an epidemiological investigation, and so you will be applying it, and so it is called applied epidemiology. Now, the fourth box, if you see, you also want to carry research activities by intervention. you want to do certain intervention, certain experiment. If you're doing experiment or intervention, can we say this as an experimental epidemiology? So this is one way of trying to understand epidemiology. First, distribution pattern, descriptive epidemiology. Second, you're trying to identify the risk factor of the disease, that is descriptive epidemiology. Third, once you have understood preventive, descriptive and analytical epidemiology, you will be trying to give recommendations for prevention and control. So can I say that as applied epidemiology? And fourth one, where you are doing experiment, you are doing intervention. So that is called experimental epidemiology. So this is the way we can understand. Let's take another way and let's question ourselves. Okay, we are trying to understand epidemiology. Can we understand decision tree? Now this decision tree is very important, students. See, ask the question to yourself. Are you doing any intervention? You will give two answers, yes or no. Let's take the no part first. You are doing intervention? I said no. Means I will not be doing any intervention, I will be only observing it. So can I say that as an observational study? When I am doing observational study, the next question you should ask to me, are you going to compare? I will say yes or no. If I say no, I am not comparing, I will be describing. It means you are describing the disease to descriptive study. You say no, I will compare. Then it becomes analytical study. When you are comparing it, then the question is, what is the direction of study? I say there is no direction. Exposure, outcome together. That becomes cross-sectional study. When the direction is forward, from exposure to outcome, it becomes cohort study. When you are from outcome to exposure you are moving, it becomes case control study. So what I have done nothing, student. You are asking that question, based on that I have replied and I have tried to understand. Intervention done? No. It means observational study. Are you doing comparison? No. If I am not doing comparison, it becomes descriptive epidemiology study. If I am doing comparison, it becomes analytical study. And then when you are comparing it, what is the direction of study? No direction. Cross-sectional study. If you are going forward, cohort study. If you are going backward, then it becomes case control study. So this is one leg. Let's take the second part. Intervention done? Yes. I am saying I will do intervention. When I am doing intervention, it becomes experimental study. Then the next question is, are you doing randomization? I say no. If I am not doing randomization, then it becomes non-randomized controlled trial. If I am doing randomization, it is called randomized controlled trial. So this is also a way to understand different types of epidemiological method, right? Now, let's come to the basic one. So, by this time, we understand that there are two types of study. First is observational, where you are not doing anything, you are only observing. And the second one is experimental or intervention, where you are doing experiment or you are intervening. Now, students think, when you are doing an observational study, the first component is description. You are describing the disease, as I said earlier, with respect to time, place and person. So when you are describing the disease with respect to time, place and person, so that helps you to formulate a hypothesis. So can I write here hypothesis formulation? So descriptive study help us to formulate the hypothesis. Hypothesis is a statement, it can be true, it cannot be true also. Now, once you have formulated a hypothesis, you have to test this hypothesis whether it is correct, not correct. So that hypothesis testing let me write here, hypothesis testing is done by analytical studies where you are doing comparison. So it can be ecological, it can be cross-sectional, case control, cohort. No? So these are the different types of analytical study which can be done to test the hypothesis which was formulated by descriptive study, and this analytical study will test the hypothesis. We'll talk in this all these studies in detail. Then the third one, where you are doing an experiment. So if you're doing an experiment or intervention, the purpose of doing is that let me confirm the hypothesis. So hypothesis confirmation. If you see, this is the way it moves. First, we formulate the hypothesis. If we want to test the hypothesis, we use analytical studies. And if you want to confirm the hypothesis, can we use experimental studies or interventional studies? So when we are doing this, now as per control, if you want to, as per control, it can be randomized control, non-randomized. As per blinding, it can be single blinding, double blinding. As per design, it can be simple, crossover. As per area, wherever you are doing field, clinical, lab. No? So these are the different ways of studying epidemiological study design. In whatever way you study, students, the concept should be clear. Now, if you have understood this, can we take one question? And I request you all to take this question. The difference between descriptive and analytic studies. Is it descriptive studies are used to test the hypothesis? Analytic studies are used to formulate a hypothesis. Descriptive studies are first phase in epidemiology, and analytic studies observe distribution of disease. Can you try, students? Anyone? The difference between descriptive and analytic studies. What is the difference? Descriptive studies are used to test the hypothesis. Analytic studies are used to formulate the hypothesis. Just now we have read this, so it will help you to answer the question. Descriptive studies are used to test the hypothesis. Is this statement correct? No. This statement is not correct, students, because descriptive studies are used to formulate the hypothesis. So this is not correct. Analytic studies are used to formulate a hypothesis. Wrong. Analytic studies are used to test the hypothesis. Descriptive studies are first phase in epidemiology. Correct. First, whenever you are trying to study any disease, you have to study the descriptive pattern with respect to time, place, and person. So the answer becomes C. And D is analytic studies observe distribution of disease. No, analytic study does not observe distribution of disease. Analytic studies help us to understand the risk factors which can cause the disease. So the answer to this question becomes C. Okay. So this is the way we have to understand the concept, and then this help us to solve the question. Okay. Now, whenever you are doing a descriptive studies, so first of all, what you have to do, you have to define the population where you are going to study. Once you have defined the population, then you have to define the disease, which disease you are going to study. So the population has to be decided, disease has to be decided, and then you have to describe the disease with respect to time, place, and person, measure the disease, compare with known indices, and formulate an hypothesis. As I said, students, descriptive studies are used to formulate an etiological hypothesis. So by this descriptive study, this helps us to reach to an hypothesis, etiological hypothesis, that can be correct also, that may not be correct, which will be further confirmed, tested by analytical studies or experimental study. So this is the procedure. You describe the disease with respect to time, place, and person. For example, we say, now this disease is very common in summer season. This disease is very common in winter season. So you are describing the disease with respect to time. Certain diseases are more common in North India, certain diseases are more common in South India, certain diseases are more common in Western countries. So you are describing with respect to place. Few diseases are more common in children, few diseases are more common in adults. So you are describing the disease with respect to person. So once you do all this thing, you ultimately are trying to describe the disease and reach to a possible etiological hypothesis which needs further testing. Now, if I see descriptive epidemiology, so what this descriptive epidemiology help us? First, magnitude of the disease. Please remember this line. It helps us to understand the magnitude of the disease, and magnitude in terms of anything. If I ask you COVID, how many cases of COVID? So you say, no, in India more than 90 lakh cases is there and death is more than 1 lakh. So you are expressing the disease in terms of morbidity and in terms of mortality, right? So this has been done. Descriptive epidemiology also help us to understand the distribution of disease with respect to time, place and person. So descriptive epidemiology is helping you to know the morbidity and mortality, distribution pattern. It also helps us to identify the risk group. And third, it helps to formulate an etiological hypothesis, right? And once you know all this, it also helps us in research, planning, organizing and implementing curative and preventive services. So this is all about use of descriptive epidemiology. Now, let's come to the other studies, which is very important. And let's start with first cohort study. Let's try to understand cohort study. Now you see, descriptive studies we have read, so it helps us to formulate a hypothesis. Now I want to test that hypothesis with a study. For example, let's take cohort study. Now this cohort study it is called by many names, and many names are not difficult to remember. It is how the study is done. So based on that, you can give many names to it. Let's say, for example, cohort study is also called prospective study, because in cohort study we move forward, we move from exposure to outcome, right? So we are moving from exposure to outcome, so we are moving forward. So it is a prospective study. When we are moving forward, we can also say as forward-looking study, right? Exposure to outcome, can we say exposure as cause to effect study? So it is cause to effect study. Exposure to outcome study. Risk factor to disease study. All these things are same. No, you are moving forward, so it becomes prospective, forward. You are moving from cause to effect, so it becomes cause to effect. The same thing can be written as exposure to outcome study, or it can be also written as risk factor to disease study. Now, students, think, when you are moving from exposure to outcome or cause to effect, so this outcome or exposure, effect, whatever you name, these are basically diseased. Can be diseased, may not be diseased. So those people who will develop disease, so they are new cases. When they are new cases, so they are incidents. So can we say cohort study also as an incident studies, because it helps us to know how many new cases have developed. So it can be also called as incident study. And you are doing a follow-up. You are moving from exposure to outcome. So you are doing a follow-up. So it becomes follow-up studies. You see seven boxes are there. 7 boxes help us to understand the inherent principle of cohort study. No? It moves forward, prospective, cause to effect, exposure to outcome, risk factor to disease, incident study, follow everything, you can make it out. Now let's take one by one. So let's take prospective cohort. No? Prospective cohort, can we say it as current cohort or concurrent cohort? Why it is called concurrent or current cohort? Because we are moving forward. So you start the study with exposure, and when you start the study with exposure, you are moving forward and you are trying to see the outcome, right? When you started the disease with exposure and you are doing a follow-up for outcome, so can we say start with exposure and move forward? So it is a forward-looking study, right? Now let's see what happens. Outcome not occurred. You have started the study when you're only exposing it, exposure. So outcome has not occurred. Exposure, you start the study with exposure. So you're moving forward to see the development of disease in exposed and non-exposed group. So this is called prospective cohort. Simple. You start the study with exposure, move forward and try to see how many people develop disease in exposed group or non-exposed group. So this is forward-looking study of prospective cohort study. The example is Birmingham Heart Studies, Doll and Hill Prospective Studies. So these are the examples. If I take retrospective cohort students, it is a cohort study in principle, but it is the name we have added now, it's retrospective. Or it is also called historical cohort or non-concurrent. Historical because it is related to history, and non-concurrent because it is not moving concurrently. Now you see here what happens. Exposure has occurred, outcome has also occurred, right? So we are starting, but again here also we'll start with exposure and forward looking study. I'll give you an example, just wait, it will help you to understand. Suppose we are in 2020, right, and I want to do a retrospective cohort. Now I want all first MBBS students, I want to do a follow-up and their admission year is, for example, 2014, right? Now, what I am here, present time. So I go back in the time in 2014 and from here I start moving forward by collecting the data of all the students admitted. I am trying to understand their, for example, I want to understand the disease pattern during the entire MBBS course. So in 2014 I collected their data and then I'm trying to follow them over the period of years. So in principle it is a forward looking study, but since in time we have gone back in the time 2014 and then moving forward, so it is called a retrospective cohort study, right? So both exposure and outcome have occurred here. We go back in the time and take only exposure into consideration. So I went here in 2014 and then I tried to understand their detail with the help of record, and then I started moving forward. How many students developed disease, how many people did not develop disease. So it is, there is an advantage of both cohort and case control study. But in principle, it is a forward looking study since you are going back in the time and checking the records for the exposure and then you're moving forward. So it is called retrospective cohort study. Okay. Examples, the famous study of fetal monitoring on neonatal deaths. So this was a retrospective cohort study. Now, can we combine both? If I combine the retrospective cohort and the prospective cohort, so it will become mixed cohort study. So you are combining both prospective and retrospective. So what will happen here? The exposure has occurred, outcome has also occurred, but in further you are assessing in future also. So I'll just give you an example. So we start with exposure and it's a forward looking study. Same thing, students. Now let's take an example. Suppose we are in 2020. I said let's go to 2014, right? And from here you start following up the students. So this is a retrospective cohort, come to 2020, and from 2020 I'll do a follow-up till 2024. So you started, so this is retrospective cohort till 2020, and from here you are doing a forward-looking study. You are trying to follow up till 2024. So it is a prospective cohort. So this becomes, it's a mixed thing. The retrospective component is also there and the prospective component is also there. So this is a combined prospective and retrospective. Nothing, very simple, just combine both. Suppose we are in 2020, start in 2014, the example which I gave, come towards 2020 and again do a follow-up for it till 2024. So you have the combination of retrospective and prospective design. The example was Cohort Brown and Doll study on radiation therapy which was done. So it had both prospective and retrospective study component. Now, so these are the different ways of cohort study doing, students. Retrospective, prospective, mixed. But the framework of cohort study and the date which, when you do the analysis of that, which help us to study the disease, is very important. So in principle, if you see, we have two groups. Study cohort means you are exposing this group. Control cohort where you are not exposing. What will happen? You are doing a follow-up. Somebody will develop disease, somebody will not develop disease. And I have given this A, B, C, D numbers. So what is this? Study cohort is A plus B and control cohort is C plus D. So this is my 2 by 2 table for cohort study. So I have just done a follow-up. I have come up with how many people developed disease in study group or in control group and how many did not develop disease. So I framed this my 2 by 2 table. Now we have to analyze the data. If we are going to analyze the data, so what we will do, we'll try to check the association between the suspected factors and the disease under study. And if there is an association, what is the strength of the association, students? We have to check this, is there any association? If there is an association, what is the strength? So let's try to understand different associations and different, how do we measure it? Now, if you see, let's come to this slide first. Yeah. If study cohort total population is A plus B, right? If I ask you, and how in A plus B, how many people develop disease? A. So if I ask you what is incidence in exposed group, because study cohort is exposed, so you will say incidence in exposed group is A divided by A plus B, and you can multiply by 1000. So that is your incidence in exposed. If I ask you what is incidence in control cohort, or those who are not exposed to the risk factor, so you can say, okay, incidence in non-exposed group, simple, it is C divided by C plus D. So this is my incidence in non-exposed group and this is my incidence in exposed group. Now when you have calculated the incidence, you see here incidence, and this 1000 is the multiplier because we express incidence in 1000. So you see in exposed group it becomes A divided by A plus B, non-exposed becomes C divided by C plus D. If incidence in exposed is greater than non-exposed, then there is a positive association. If it is equal, there is no association, and if it is less, there is negative association. Just to give you an example, negative association, because positive we know many things. If you do exercise, yogas, hypertension, diabetes mellitus is less. So there is a negative association between exercise and hypertension. So this is the way you check the association between the suspected factor and the disease under study. Now once you have checked this, you have to check the strength of the association. And how do you check the strength? Please try to understand. You have different methods, measurements: relative risk, risk difference, attributable risk, absolute risk, population attributable risk, and population attributable risk proportion. Try to understand this, students. Now, it's very easy. Let's come to this an hypothetical example I have taken. There are 3000 people. Just try to understand this. There are 3000 people in totality. I'm checking smoking with lung cancer. So I have one group is exposed with smoking, other group is not exposed with smoking, and these are the numbers. So smokers total population is 2000 and non-smokers total population is 1000, and these are the numbers who have developed diseases. Now first question, if this is my 2 by 2 table, students, first thing what I say, I ask you how many people developed lung cancer in smoking group. So if you see, it becomes 120, right? What is the total population who were smoking? 2000. So if I ask you what is the incidence of lung cancer in smoking group, so what will you do? You will say, okay, 120 people developed lung cancer out of 2000. So 120 divided by 2000 and you are expressing in 1000, so it becomes 60. No? So this is my incidence in 60 per 1000 population. Yes, in 2000 120, so in 1000 how much? 60, simple. So 60 per 1000 is my incidence in exposed, right? We got it. Now the similar question I ask you, that what is the total population who are not exposed? 1000. How many people developed in non-exposed group lung cancer? 20. So 20 people developed, lung cancer in non-exposed group. So my incidence in non-exposed is 20. So I have my incidence in exposed group, I have my incidence in non-exposed group. Okay, now when you have this, can you take the ratio of both, which is called relative risk or risk ratio? So incidence in exposed was 60, non-exposed was 20. So if you take the ratio, it becomes 3. So what is this 3 now? This is relative risk. So what does this mean? It means that smokers are 3 times at a greater risk of developing lung cancer than non-smokers. Simple, because the relative risk is 3, more than 1. If you remember, if relative risk is greater than 1, there is a positive association. Here we have relative risk as 3. So the association, so we can say it is a positive association. If this could have been 1, no association, and if it is less than 1, it is negative association. So this is the way we interpret relative risk. Since here in this example which we have taken, relative risk is 3, so we can say that smokers are 3 times at a greater risk of developing lung cancer than non-smokers. Fine. Okay. Now we know incidence, how it is calculated, we know relative risk. Now can we understand what is risk difference? Risk difference, as the word says, difference. So can we say what is the difference between incidence of the disease among exposed and unexposed? So what is the difference? So you have incidence in exposed, you have incidence in non-exposed. Can you calculate your risk difference? So it will be 60 minus 20. So it becomes 40 per 1000 population. This is my risk difference, right? So I've just subtracted the non-exposed incidence from the exposed incidence and I got my risk difference. Now this is risk difference. So can we calculate now attributable risk? Let's try to calculate attributable risk. Now this attributable risk is, we have to take the ratio of risk difference, which I have already calculated, RD, risk difference, ratio of risk difference and incidence of the disease among exposed. So if you remember, RD was 60 minus 20, which is 40. This is my risk difference. So 40 divided by 60, because this is my exposed group incidence, and just express into 100 percentage. So your value is 66.6%. So this is my attributable risk. So can I formulate a formula? Incidence among exposed minus incidence among non-exposed divided by incidence among exposed, and just express this into percentage. So it becomes attributable risk, right? Now in this example, the attributable risk is 66.6%. Now what is this? What does this mean? Please try to understand this. Attributable risk, the extent to which smoking is attributed as the cause of lung cancer among smokers. So just to take an example, 66.6% of lung cancers which is there, we can attribute that to smoking. So we know this, that if we can remove smoking, if I remove smoking as a risk factor, I will be able to reduce lung cancer by 66.6%. Now you tell me, students, if you know this percentage value, it is 66.6% or any value which comes, and you know this understanding that if I remove the risk factor, we will be able to reduce the disease, in this example lung cancer, by 66.6%. Now if I ask you, attributable risk is more important or relative risk is more important? What was relative risk telling? Relative risk was telling only that 3 times more there is a possibility of lung cancer in smokers than non-smokers. But that doesn't help much. But if I say that if you remove smoking as a risk factor, then you will be able to reduce the lung cancer by 66.6%. So definitely this indicator is better than relative risk. Okay. So you see this last box, higher the attributable risk, greater the reduction in the incidence of disease, because you know that if you remove the risk factor, you will be able to reduce the disease by that attributable risk percentage. So it is more important than relative risk. Okay. Now take this question. The difference between the incidence in exposed and non-exposed group is best given by relative risk, attributable risk, population attributable risk, or ratio. Now, if you see this question, the difference between the incidence in exposed, so incidence in exposed minus incidence in non-exposed, right? This is the question they are asking. So with our understanding, it is risk difference. If you see here, but you don't have risk difference as an option. So you have relative risk, attributable risk, population attributable risk, or odd ratio. Now odd ratio will not be the answer because it is in case control study. So let's remove this first. So we are left with relative attributable population. You know what is relative risk? Incidence of exposed divided by incidence of non-exposed. So this will also not be the answer. Now we are left with attributable risk and population attributable risk. Just now we have studied this. So it is incidence among exposed minus non-exposed, and you are expressing this in percentage, and the denominator is exposed incidence. So this fits here. So the best option to this question is attributable risk. So go with attributable risk as an answer, right? Okay. So we have understood relative, we have incidence, relative risk, attributable risk. Now let's try to understand what is absolute risk. Absolute, as the word says, absolute, students. So absolute, you know, I'm not interested whether the person was smoking, non-smoking. I'm interested how many people developed lung cancer. Tell me that. So you will say, okay, it is 140. 120 plus 20. So it 140 people developed lung cancer. What is the total population? 3000. So in 3000 population, 140 people developed lung cancer. Can you express this in percentage? So what will you do, students? 140 divided by 3000 into 100. So if you calculate this percentage, it comes at 4.67%. So this is your absolute risk. Simple. Out of total population, 140 people developed lung cancer. So this is your absolute risk. It is expressed in percentage. Okay. Now, let's try to understand what is PAR, which is population attributable risk. This is important because we have understood attributable risk. So let's try to understand population attributable risk. So in this, we should move forward. Let's try to calculate incidence in population. I'm again repeating, incidence in population. Total population is your how much, students? 3000. How many people developed lung cancer? 140. So you say 3000 population, 140 people developed lung cancer. So how much people will develop lung cancer in 1000? So that is the way we calculate incidence. 140 by 3000 into 1000. So it becomes 140 by 3. So it is around 46.6. So you have your incidence in population as 46.6 per 1000 population, right? This is your incidence in the entire population. Now you have this incidence now in the entire population. From this, can you subtract, minus, can you subtract incidence in non-exposed? You know what is the incidence in non-exposed, which is 20. Out of 1000, only 20 people have developed lung cancer in non-exposed group. So, students, what you do, incidence in population minus incidence in non-exposed. So, this gives you population attributable risk. So, 46.6 minus 20. So, it is 26.6 per 1000 population, right? So this is your population attributable risk. Simple. So what I did, I subtracted the non-exposed incidence from the incidence in the total population. So that is your population attributable risk. Okay. Now once you so this is better than attributable risk also. So if I am a public health expert, I am trying to formulate a policy, so I will be more interested in population attributable risk because it is giving us an information about the population, right, in the entire population. So this becomes better than attributable risk. Now can you express this 26.6 into percentage? So that becomes population attributable risk proportion, PARP. So population attributable risk we have already calculated, which was 26.6. Incidence in population we know it is 46. So this 26.6 in this 46 is how much percentage? That is 56.65%. So this is your population attributable risk proportion. Just out of incidence in total population, what is population attributable risk? I have expressed that in percentage. So that becomes population attributable risk proportion, right? So these are the different measurements which is done in cohort study, starting with incidence and exposed, non-exposed. Then you take the ratio, becomes relative risk. Then you you just subtract non-exposed from exposed, become risk difference. If you express that in percentage by taking denominator as exposed, it becomes attributable risk. So that indicates that if you remove the risk factor from the study, so you will reduce the disease in that group by that percentage. And if you are if you are subtracting the non-exposed incidence from the population incidence, you get your population attributable risk, which will help you to understand the attribution in the entire population. And when you express that in percentage, it becomes population attributable risk proportion. Okay. Now, let's take one question, students. Try this. So, whether we have understood or not, 100 individuals are diagnosed with lung cancer in a population of 1 lakh. Out of 100 patients, 80 were smokers and 20,000 were smoker in total population. So they are telling you to calculate population attributable risk. Let's try to calculate this population attributable risk. Anyone? Can anyone do? Anyone? Okay, let's try to understand this. Let's try to solve this. So what is the total population? I write the total population as 1 lakh. Let me write here. 1,000, 10,000, 1 lakh. In 1 lakh, 100 individuals are diagnosed with lung cancer, right? So this is diseased. This is the total population. I am telling you what is, let me write here, what is PAR, population attributable risk. Just now we have read simple incidence in population minus incidence in non-exposed. Simple, this is PAR. Now let's try to calculate this, then only we'll be able to do. So in 1 lakh, 1, 2, 3, is this 5? Yeah. In 1 lakh, 100 people have developed lung cancer. So in 1,000, how much? That is the incidence. So it is 100 divided by 1 lakh into 1,000. So it becomes 1. So my incidence in population is 1, students. Done. I have this value I have got now. The only thing I have to calculate now is this. Now read, out of 100 patients, this 100, 80 were smokers. When 80 was smokers, it means 20 are non-smokers. When 80 are smokers, 20 are non-smokers. Okay. Now read the next part of the question. 20,000 were smokers in total population. So 1 lakh population, it's saying that 20,000 was smokers. So what is 80,000 then? Non-smokers. Simple. I have to calculate non-exposed incidence. So total non-exposed population is 80,000, and out of 80,000, 20 people developed lung cancer. So in 80,000, 20. So in 1,000, how much? Simple mathematics. 20 divided by 80,000 into 1,000. So it becomes 1 by 4. Now your incidence in non-exposed group, just wait, non-exposed group is 1 by 4 now. 1 is your population incidence. Now 1 minus 1 by 4, this I have to do, which is the formula. So it becomes 3 by 4. If you 3 by 4, if you convert this into percentage, it will be 75%. So your answer should be B. Right? So your answer should be B. So if I know this population attributable risk, what it is, and then we have understood this. I did not made any 2 by 2 table. I have just taken the question step by step, and I have tried to calculate, and it has become easy. No, we don't have to remember anything, no formula and everything. Just population attributable risk. So you want to attribute the risk in the entire population. So you have to know the incidence in the total population, and from that you have to remove the incidence of non-exposed. You get your population attributable risk. So this is the way it is calculated here, students. Okay, I'll stop here, and I hope we were not able to complete, but we'll be trying to complete in the next sessions, so that we have a proper understanding of different types of epidemiological methods with the calculation, with tables, and how do you interpret that. That is important, because that helps you to remember the topic for long term. No need to learn formulas. It is just an understanding, students, so that it becomes easy and you understand the concept and it sticks to you for a long time. I hope the session was helpful for you, and thank you, students, for watching. Take care. Bye bye.